teaching at one of the sessions in the hospital, teaching us what indeed it would mean to have us listen to community point of view, to be community advocates, and to hear in a different way. So cultural humility has 4 points to it, and they are in this handy-dandy little handout here, which is the piece that Jan Mary Garcia and I wrote in 1998. And the 4 parts are pretty straightforward. We think that in order to engage with the issues of culture and difference successfully over time, we need to each be self-reflective and see ourselves as lifelong learners. Think about interviewing as being patient-focused rather than physician-focused. To be in relationship with community in a way that we are engaged in advocacy and community-based care. And that finally, institutions match this process with institutional consistency, meaning that the institution is involved in the same way with these activities. I want to make a few comments about humility, since I've given this talk many times, or not this one exactly, but talked about cultural humility, and often I find that physicians recoil a bit from the term humility, and others do as well. I'm not suggesting at all that you should be weak, not have an opinion, not know who you are, in fact, quite the other. Important to know who you are, to know what you think about these issues, to know where you came from, your own history, your own explanation, your own relationship to culture in the world. And at the same time, understanding the distinct power imbalance that exists when one is the provider or the physician relative to the patient, to hold a stance of quiet and even a bit of reserve and meekness even, so that you are able to hear the views of the person you are in communication with. And to put it totally in context, we use the term to remind us to not be so arrogant or prideful or really think that we have to be all-knowing and all-knowledgeable and know everything about everything in the world, which of course we can't. Even though there is a culture of medicine, at least that I grew up with, I'm not going to say what yours is, because I'm not here with you. But I grew up in a culture of medicine that suggested that, you know, the privilege of being a doctor meant that I knew everything about everything. I know this much about a little bit of things. So that's where the term comes from as well. And we encourage you to think about it like that, because we feel like entering into the realm of culture and the discussion of culture and difference, it can almost give you an aha relief moment that, oh, great, I'm not expected to know everything about every single culture in the world. So here are the tools to get to this. It takes courage and humility, which I've explained, I think, to some degree on your part as a practitioner. Important to acknowledge and turn around the inherent power imbalance that exists in the physician-patient hospital staff dynamic. I think without saying entirely too much about this, how many people in the room have been a patient? All right, so you get it. I mean, I still feel like when I go to the doctor often, I lose my language. I'm a pretty verbal person, but I can get in there and just be changed, be diminutive, be not my full self suddenly, because I recognize who's got the power. We are encouraging you to do your best to shift that power imbalance. Certainly to de-emphasize some sense that you can walk in with a code card, much as we do, and I do encourage you to do this, to walk into a code with a list of the drugs and the dosages and who gets what, when, where, and under what circumstance. I do encourage you to do that. But in this circumstance, to walk into a room instead not with a back pocket that says, for the people who live in the part of Guatemala that's rural, I should not touch their hand. No. To instead think, what are some framing questions I can use, and how can I respectfully and curiously engage in this dialogue with the families I'm seeing? And to be part and parcel of community-led, non-paternalistic advocacy work. And again, which I will continue to highlight, that institutions themselves must be shining examples of this. So your institution must indeed be exhibiting humility, must indeed be in relationship with community, must indeed be able to say, I don't know, must indeed be able to change the face of who makes up the institution. So a short list, again, of what cultural humility is. It's about relationships, lifelong learner, self-reflection, patient as teacher, redressing power imbalances, no code cards, and culture, and institutional consistency. The relationship piece with families, to know that this will be built over time, and with individual patients, that it's something to be revisited each and every time one is visited by families. I often like to think when I go in a room that I'm having the great privilege of walking into the life of someone who I'm just meeting for the first time. And over and over again that will occur. Patient, provider, and system need to see this relationship as being built over time. Patient as teacher, to know that in each instance it is possible to have respectful, curious inquiry with people that we are in a room with, and to anticipate multiple cultural identities, using that piece of information I showed earlier. Without asking, it's impossible to know if today my voice is hoarse and I just have a little cold because I just have a little cold, or that my voice is hoarse because I was screaming at a rally yesterday, you know, and that it was a rally about discrimination. You have to ask me. You have to ask me. It gives you a window into other cultural identities. And to enjoy not knowing. To enjoy feeling like, well, I'm walking into another wonderful revelation of a relationship. The self-reflection and lifelong learning piece has some questions that go along with it, and there are others that I think you will come up for yourself as well. I happen to think that this is in some ways the heart of the work, and that if we, again, aren't certain of who we are and where we stand on issues of our own culture and multiple cultural identities, it's very difficult to think that we can then hear about it from others. It also can impact how we interact with people. The Institute of Medicine report did make plain that, like it or not, the biases, prejudices, stereotypes, and point of view of physicians are brought into the room. I thought, oh, well, okay, this is not new news. I'm a human being. I have biases. Yes, I do. I have some stereotypes. Oh, yes, I do. I try to understand them and know them, but they're there. And when working with families, here are some of the questions that I ask myself. What do I know about this cultural group? And how do I know that it's true? Where did I learn it? What's happening for me with this group that might shift how I offer resources or how I hold the resources close? Remembering that the privilege of being a physician is also that we have been given keys to a kingdom of resources that others just don't have yet. Not that it should be that way. Hear me really clearly. But that's the way it is right now. So the distribution of resources based on my feelings about this group, what's happening with that? And if I need to learn things, how do I learn them? And where do I learn them? Balancing the power imbalances really means that we have to step out again as physicians. I would say step out onto the end of the limb where the best fruit is and see that each patient, each group really is rich teacher for us. Not just on the content of culture, but on all of the isms and the taboos that I think we still walk away from. This is too short a time to walk into those conversations, but community will teach us to what degree racism, sexism, homophobia, classism, the many, many isms of our time impact health and their health circumstance. And then finally, to be certain that we are, as much as possible, being in partnership and being facilitator and negotiating best circumstance for our patient's outcome. So just in summary, since I have 3 minutes, I think, cultural humility in practice really does best in an intimate and personal environment, and you're going to have that opportunity this afternoon. And I would encourage you to foster that in the rest of your medical education, places to really learn with each other in intimate ways, and to enable the expression of the patient's story. Bring to it, and we do bring to it when we teach in this way, social science training, art, literature, much of which will give us this sense of the content of culture and health in a way that my standing up here could never do for us. That community teaches, this is a solid principle for us, and the importance of being in partnership with community. We think this is a useful way to approach the discussion of cultural competence, especially in the next 20 years, because knowledge is important, but it's going to be insufficient. You can walk in there knowing just reams and reams and reams and reams about the cultural practices of whoever, and it just won't be enough, and you'll experience that this afternoon. And that culture is forever changing. I can guarantee